This is Megaphone from Medvale Media. I'm Dave Sell. This is where we hand the megaphone to healthcare leaders to share their thoughts, perspectives, and the occasional rant about the increasingly dynamic world of healthcare. And today we're privileged to be joined by Mr. Neil Meltzer, President and Chief Executive Officer of LifeBridge Health, based in Baltimore, Maryland. Neil, thanks for joining us.
My pleasure. Happy to be here, Dave. Thank you.
Well, Neil, as we kick off, could you share a little bit about your background, how you got to where you are today, and touch on a little of LifeBridge, and then we'll get under the hood a little bit together.
Sure, happy to do so. I kind of call myself the accidental CEO because my career path never was to become the leader of a healthcare system. I began my career really in nuclear physics, studying the impact of nuclear power on the environment back in New England, where I was born and raised, and really plan to remain. At the time I graduated, the Roe nuclear power plant in Vermont was the second nuclear power plant coming online, and I was a bit of a tree hugger. Had a green armband for Earth Day, my 501s, my Birkenstocks, and I was hugging trees and making sure that they would be saved from the ills of nuclear power. But at that point in my career, there were not a whole lot of jobs for world savers. I was offered a public health scholarship at Tulane University, took that and realized that I could kind of saved a quarter of the world, a quarter of a city. Did my administrative residency out at Lay Clinic in Boston, worked in two healthcare systems up there, was recruited down to Maryland to be the vice president of miscellaneous, as I call it, at Sinai Hospital in Baltimore, which at that time was a freestanding hospital in the shadows of Johns Hopkins and the University of Maryland Medical System. So I really planned to be there for about 5 years, had a 2-year-old, and was going to go back to Boston to raise our family in the shadows of our extended family. It just never happened. As I was down in Maryland, opportunities kept arising. I was eventually named COO of Sinai. Sinai eventually merged with another health system, and I became the CEO, or the president, at least, of Sinai Hospital. And about 12 years ago or so, I was named the CEO of the health system. And since that time, we've grown from what was a $350 million teaching hospital, which was Sinai Hospital back in the late 80s, to just about $2.2 billion now, with about 15,000 employees across 134 sites, primarily in central Maryland, but also southern Pennsylvania and northern Delaware. So it's been a fun ride. LifeBridge Health really is a comprehensive soup to nuts organization that really spans from wellness with LifeBridge Health and Fitness, which still remains a top 100 health club in the country, all the way through hospice. And we like to consider ourselves the organization with a community conscience. If you take a look at where we sit and how we sit, there are people that say we shouldn't exist. We're one of the smallest health systems in the state. We are 8 miles from the Johns Hopkins Health System, their main flagship hospital, 8 miles from the University of Maryland Medical System, yet we're thriving, and we've been upgraded by the payers twice in the past decade or so. So I'm pretty proud of the team we built and the work that they're doing. We have a lot of community outreach, a lot of community programming. We try to really address the needs of our local communities in multiple ways. And we take things on that are a little more challenging.
Neil, it sounds like for about 36 years, you've been leading healthcare organizations, including, as you said, Sinai Hospital in Baltimore, and now LifeBridge. So many significant changes over that period of time. Are there some that really stand out to you in your experience that have been those fundamental changes in the industry?
I think, as I look back, certainly the employment of physicians was a major change from when I began to where we are today. As I look to our community, the vast majority of our employees, of our physicians in our communities, are employed either by us or by PE companies from around the country, but largely healthcare employed or health system employed. I think the other thing is a major focus on population health and focusing on trying to keep people healthy and out of the hospital. That's near and dear to my heart. I think that's something that we're not doing enough of. I think we've been a sick care industry and not a health care industry, and there's a lot more work to be done on the health side of what we do. And that's what we're trying to do, at least organizationally, and I see the industry moving in that direction as well. I see a lot more focus on nutrition as medicine, a lot more focus on trying to address chronic disease issues before they happen. And I think as you begin to take a look and put your ear to the ground with AI, at some point it may be considered barbaric to wait for someone to uh, get ill before you begin treating, because largely you'll be able to have enough data or enough information on individuals to be able to address their needs in advance of their being identified as someone who is ill at that point in time.
It's fascinating you bring up population health in that context. Recently, I've been talking with an individual that has a very large EHR-based practice covering about 70% of New Zealanders. And
Wow.
they find truth in the data and provide nudges to physicians, not directives, but nudges, just saying, you may want to be asking about this condition when you meet with your patient today. So agree with you completely that the ability to use artificial intelligence and really leverage it with the data. We tend to be data rich and information poor in healthcare,
Correct.
and really trying to blow that out. Is that an approach that you're trying to promote as it relates to population health?
It is. It's something that I keep thinking about on a bigger scale, however, because when you think about data, it's not just the health data that we have today. If you go to a supermarket and you're buying cookies instead of celery and carrots, or you go to a department store and you're buying running shoes as opposed to, a tie, you have that information exists. And how do we begin to take all that information, pull it together, and or that data exists, excuse me, and how to make that information that is useful to begin to predict. You think of AI also just applied directly to healthcare today, and eventually, hopefully, it'll be able to allow us to identify volume trends or volume in a much more predictable way, which allows us to manage staffing in a much more predictable way. I think there's a huge opportunity here that's just barely beginning to get tapped.
And again, you touch on something that I think we've all probably seen or are using, which is AI to predict respiratory illness peaks,
Mhm.
and being able to really wrap our hands around what it's going to take to think about when do we reinstate masking protocols? What are we going to be doing in the clinic environment? The LifeBridge website states your mission statement, your vision statement, but of real interest to me is that you also talk about culture and you use two words to describe it: care bravely. Can you unpack that for us?
Sure. I guess a while back, and this goes back pre-pandemic, and it was interesting that it happened right before the pandemic because it was so appropriate during that pandemic period. But the whole idea was that we are purpose driven, that we are an organization that uses that purpose as a filter through which we make all decisions. And the whole idea was that we do the right thing even when it's the hard thing, and we come to work every day and do it over and over and over again. And the folks that are on the front lines, whether they're in the hospitals or out in the community, are doing some things that are extremely brave on a day-to-day basis. And what we try to do is turn this into more of a movement than a campaign or a tagline. So there are Care Bravely stories that people are writing themselves or patients are writing about. And what we're finding now in compliment letters from the patients in the community is that something was a Care Bravely approach by an employee, or they experience a Care Bravely moment during their stay in the hospital or in a physician's office or in an ambulatory setting. And it's been kind of interesting because it's taken on a life of its own. So the employees are kind of proudly wearing the Care Bravely moniker. The community sees Care Bravely as an act, something that we do on a day to day basis, and it's become something which is now worn on hats and shirts and t-shirts and all sorts of clothing, in part because it means so much so deeply to our team. And well, I've got to say, initially there was a lot of pushback from folks in the community saying, "Yeah, what's Care Bravely all about? And what's this mean? And how does it work? And it sounds so ridiculous when you compare it to look at all the other health systems out there with the same old taglines."
Sure.
We wanted to make this more than a tagline. We wanted to make it part of who we are and what we're all about. And
Well, when team members are willing to wear it on a hat or a shirt, you know you're getting traction because they find not just pride in that, but the willingness to say to the community, "This is who I am, and I'm proud to be part of it."
but what was interesting is it came about right before the pandemic. So as employees were gowning up and wearing spacesuits for 2.5 years in the hospitals, all of a sudden that Care Bravely uh, name, that movement really became important and powerful. And they said they are caring bravely every single day. They're walking in the four walls of that hospital, trying to care for people who are extraordinarily um, um, you know, contagious.
Well, looking at the list of services that are available from LifeBridge and in the LifeBridge family of entities, one would not guess unless they were told that you are not the largest health system in the state. So Hopkins and U of M may be on either side of you. But when you look at that list, the significant role that you must play in public health and the lives of everyday people in Maryland seems significant. So, how do you make the determination with your leadership team of when to lead, when to partner, when to support? It's that walk ahead of you, walk beside you, walk behind you at the right time. What kind of conversation do you have to determine the right time and the right role?
Well, I think from the second portion is probably the easiest. The right role is based on what our communities need. And we do a community health needs assessment as every other organization does every few years. But one of the things we're finding is that a lot of what the community is asking for are things that aren't necessarily traditionally healthcare. So identifying the issues are difficult. When it comes to creating or partnering, what we have found is that we know what we do well, we know what we don't do well. We sit around my table as this executive leadership team and make those decisions based on what we feel our capabilities are. And oftentimes we'll start with a partnership and we'll end with ownership because we're learning as we go. We now partner and own 7 nursing homes, a independent assisted and memory care facility. The entry into urgent care was something that was brand new. We created a partnership there, but over a period of 3 to 4 years, we learned the business and were able to assume the responsibility 100% for that business. And that's tends to be how we look at things. Now, at the same time, we take a look at community needs, and one of the community needs we found was for staffing. Staffing is difficult everywhere, as you know. So we created a health high school with a local really school system, and we partnered to provide some of the teaching, but the students wear scrubs with our name on them, and we bring them through an entire really 4 year process where they're getting experience in the hospital as well as getting a graduation right at the hospital as well. And the intent there was to take students who may not become physicians in the future, but would become paraprofessionals in one way or another. And they're fed into a community college, which is fed into a 4 year college to the extent that they're interested in doing that. That's one example. We also felt that there's a shortage of primary care physicians. So we created a regional medical school with George Washington University. So now when students apply to GW for medical school, they either apply to the DC campus or the Baltimore campus. The first two didactic years are done either in Washington itself or online. And the last two clinical years are done either at our flagship hospital, Sinai Hospital in Baltimore, or at the GW campus in Washington, D.C. We're about 35 miles apart, so we can share staff, which makes it easy. But they're two very different populations. And our focus on our medical school in the future, and hopefully these students will apply for residencies at our facilities, but our focus is really primary care, innovation, and population health. So we're trying to attract students who want to work in a community health setting, excuse me, similar to what LifeBridge Health serves. It was a unique model. It was something that we felt the community deserved and needed. It took about 3 years to get through this process. One of the other local university health systems fought us on this for about a year, but we were able to get through that. And now I'm proud to say that we're entering our third year of this program.
That's fantastic. So after the students wear your scrubs or scrubs with your moniker on it, I would imagine that they become somewhat attached to the culture, and so you're getting the best and the brightest as they matriculate through the process.
That's our hope. We've actually started a second program now. So there's one in Baltimore City, one in Baltimore County. And if this continues to work, hopefully we'll expand it yet again. We just created a nursing program with one of our community hospitals and with the local community colleges also, in an effort to create additional nurses for our community. And the nursing school is actually renting space on the grounds of this particular hospital, Carroll Hospital in Westminster, Maryland. And so the students will be taught really at the hospital. And obviously, the goal is to try to keep those nurses to the extent we can within the health system.
So in this same theme of population health, leading and supporting, it doesn't go unnoticed that you've put a stake in the ground around gun control,
Yeah,
or certainly um, an aggressive move statewide, but you're part of that and endorsing it. Can you talk a little bit about the Marylanders Against Gun Violence?
sure. There has been a growing issue in the state of Maryland regarding gun violence generally. It's not just in Baltimore City. So when we do community health needs assessments and look at the social issues that they raise, gun violence is number one or number two always. And we've been struggling for the past few years to figure out how we get our arms around. Now, we do have a violence intervention program called the Center for Hope. And the Center for Hope is a program, it's the umbrella organization that supports our domestic violence program, our sexual child abuse program, our physical child abuse program called Family Tree, and our elder abuse program. We've assumed responsibility in the city of Baltimore for 50% of what's called the Safe Streets program. It's a program that Baltimore adopted from Chicago, actually, to address violence in the city of Baltimore. So we hire ex-offenders who are coming out of the prison system to work and intervene in violence in the city. And we've had over 1,000 interventions this past year in the city of Baltimore, and we've reduced the number of gunshot wounds coming into our hospitals by 34%. And these aren't going elsewhere, they've just been reduced. So we are seeing an impact. But
That's
beyond
impressive.
that, yeah, thank you. But beyond that, we found that, and this was shocking to me, that Maryland is the number one state in the country for trafficked guns. And part of the reason for that is the gun laws are so strict in Maryland that it's easier to buy a gun on the black market than it is to buy a gun legally. So as we've looked at this, we found that the pipeline, what we call the iron pipeline, is Georgia up into Maryland. I've been honored to speak at the White House twice now. They got an Office of Gun Violence Prevention, which may or may not continue with the new administration. But they were able to share some statistics with us. And what was interesting is that 2/3 of the gun violence in the state of Maryland is being promulgated with guns that are brought in illegally into the state. So we're the number one state for traffic guns, and 2/3 of the violence with guns in the state of Maryland is with traffic guns. So we said we needed to do something. So we started something called Stop the Iron Pipeline. And we did a 3-minute video essentially of someone being trafficking a gun up from Georgia up into Maryland, which was somewhat controversial. We launched this about 3 weeks ago. We've asked people to sign a petition to the governor and the attorney general in our state, asking them to be more active with addressing this issue. We know that Letitia James in New York was able to sue the ghost gun manufacturers and win. And we think that the state of Maryland could do something in terms of putting pressure on the other governors up and down the Route 95 East Coast to try to stop some of that trafficking. We're also asking people to provide information on their experience with gun violence in the state and post that online. We had a Maryland-based local rapper create a song. He's got 16.5 million followers. So that's been posted on his site as well. And all of a sudden, we're getting a huge amount of interest in this campaign. We're told we're the only health system in the country to take this on. So I'm kind of proud of that. At the same time, it also puts us in the spotlight for gun traffickers, and we recognize that the traffic could go elsewhere, but we're hoping that we can create some kind of pressure on legislative bodies to reduce the trafficking. This was a third rail issue, and we didn't want this to be a red or a blue issue. So we said everyone should be against trafficked guns, and everyone should want to reduce violence in our state with the use of these traffic guns. So it's been a very interesting process so far. It's only been 3 weeks.
Well, care bravely may be a cultural touchstone, but bravely leading is what you're talking about. Kudos to you and your leadership team, because you're right. It is a conversation in many health systems and hospitals around the nation. And because it is that third rail sort of issue, it's something that people feel passionately about, but rarely do we see the kind of action that you and your team have taken.
Thank you. I appreciate that very much.
Another issue at the top of most every senior leader in healthcare's list of concerns is professional burnout of the people who actually provide care.
Yep.
Can you comment on how you and your leadership team are addressing this issue?
This is a tough one. Burnout is something that there's not an easy answer to. And what we're trying to do is provide not only the support services necessary for individuals who are facing burnout. We have a number of those that we put into place, and you can be anonymous or not anonymous to the extent you choose. But we're also trying to change our staffing, change technology, and put things into place which reduce the workload burden, whether it's a nurse, a tech, or a physician, because we're finding the burden isn't just physicians. We do think the use of technology will help a little bit. We're using ambient listening in physicians' offices now. We're using Copilot to take minutes in meetings. We're using virtual nursing now to reduce the burden of what a nurse does in a patient room. We're finding that actually not only is that working, it's improving patient satisfaction. So that was a nice little addition when we saw that. So we're trying to take a multi-pronged approach from a day-to-day basis and a personal standpoint. We're trying to focus on staffing and focus on their own mental health and making sure that we're not burning people out by working them too hard. We're also trying to implement technologies which will help reduce the day-to-day burden and the amount of time that they spend in dealing with significant issues. What was interesting is we hear folks often talk about physicians and nurses working at the top of their license, but when you talk to physicians and nurses, they say they don't want to work at the top of their license 100% of the time because there's absolutely no time to begin to decompress a little bit. Sometimes it is good to have a less stressful patient encounter, whether you're a physician or a nurse or another caregiver. And when you think about it, it makes a lot of sense, because if you or I were to be under constant pressure all the time, working at the very top of everything we do, it would put a lot of emotional pressure on, and I'm sure add to the burnout as opposed to reduce the burnout. So we're keeping that in mind too as we think about how we work with our caregivers.
Well, thank you for explaining the approach that you're taking. There's a lot of wisdom in understanding the fact of operating the top all the time. Is little like listening to a Whitney Houston song where she goes up to the top of the register, stays there for 4.5 minutes, and by the end, you're exhausted.
I
And
love that analogy.
so, well, you're welcome to it. I'm sure I stole it somewhere, but it is fascinating to see how people are just now beginning to really appreciate the pressure that people who actually provide care are under on a daily basis. So, thanks for unpacking that. Um, Neil, the views and opinions of most every aspect of the healthcare industry continue to intensify on every front, legislatively, from the regulators, from the general public. If you think about pharma manufacturers, price transparency, health insurance business practices, PBMs, hospitals and health systems are all headline makers. From your perspective, What is it that's turning up the volume on the issues?
A couple of things. Number one, I think part of it is the generational shift, and I think we're seeing a lot of focus on consumerism. People who want choice, who want access, who want convenience, and I think that's driving a lot of what's happening. Now that's number one. Number two, I think people are now beginning to understand the insurance industry. I think for years, people truly didn't get what they were buying. And as I've explained to people that your house insurance does not pay your electric or your water bill, and your car insurance doesn't pay to have an oil change in your car. Yet people have always been under the assumption, regardless of the plan they bought, whether it's a high deductible or it's a plan, they think it pays for everything. And I think people are now beginning to understand that. I also think hospitals are facing a situation where we're spending an enormous amount of time, talent, and money on fighting denials. And unfortunately, with the United Healthcare CEO murder, I think that's only heightened the knowledge, the understanding, and the desire to begin to address some of these issues. I think we're just at the toe of the curve because although it's kind of been under wraps for a while, I think there's a lot of work that is going to be done that will need to be done. My guess is the new administration will begin to tackle some of this. How it will play out, I'm really not sure. But I also think that it's something that is long overdue. If you take a look at society in America today, I'd venture to say that quite a large number of hospitals are largely or to greater than 50% Medicare and Medicaid, so government payers anyhow right now. And I think we're going to see some kind of a shift because of that. Insurance companies were initially meant to be clearinghouses, and they were to process claims and payments. They weren't to be for-profit entities. And I think what's happened is since they've become for-profit entities, the denial rates have gone up. The cost to the system has gone up. Certainly, we're paying a whole lot more to fight denials, and we fight every single one of them than we ever have in the past. And that just adds to the total cost of care for society. So I think there's a lot of change afoot right now.
It's more than just a canary in the coal mine moment. It is time for the conversation, and we'll be taking a lead on that in the future here at Megaphone and in Medvale as well to accelerate the conversation among people that are actually part of the industry who see the need for change as you've outlined. Neil, when you gaze into your crystal ball, what do you believe are the big challenges
Oh
for
man.
health systems in the near term and take it out a few years?
Okay. Some of the same ones. Staffing is continuing to be a big issue for us, and hopefully technology will help a little bit with that. Um, I think financial pressures. We are in a hostile reimbursement environment. Technology integration. When you take a look at everything in a health system, whether it's inpatient or outpatient, technology is driving so much, and virtually every piece of equipment has a chip in it. So I think cyber risks is something else. When you think about the fact that with an appropriate placement of a virus, you could shut down all the ID pumps in a hospital. That's scary. That's a whole lot more scary to me than losing my social security number. Um, so I think those are big issues. Supply chain. I think one of the things we've learned is that you can't put all your eggs in one basket. And although Change Healthcare wasn't a supply chain issue, we use Change Healthcare as a clearinghouse, and we realized that because we essentially put everything in that, we were ground to a halt. So I think supply chain generally, we need to have multiple players in that field, and we as healthcare systems can't put our eggs in one basket. I think private equity is something to watch. We've seen private equity begin to impact how people provide care, where people provide care. As an example, we've seen a 20% reduction in our acceptance rate of patients into nursing homes that are now owned by private equity that weren't in the past.
That's
Which,
significant.
Yeah,
That is,
it is very significant. It increases length of stay, reduces, impacts throughput into the emergency departments, et cetera. The whole 340B program, something else. But I think, the exciting part in the future, quite honestly, I think is technology. As I think into the crystal ball, and as you and I almost started the conversation with, thinking about data and how data can be turned into information and how information can be used to appropriately try to address issues with patients prior to them, impact having the impact of disease. And I'm excited about that. People were all scared about AI. I looked at AI kind of like I look at the internet. It's something that just started coming out. We're all trying to figure out how to use it. Yeah, it can be used for bad, but it can also be used for a whole lot of good. And I'm really hoping that this sort of creates an opportunity for us to um, treat patients a little bit differently. And the other thing I think about, into the future, um, there are two main EMR providers in this country. There are a whole lot more than those two, but you think of Oracle and you think of Epic. I think they're ripe for disruption. I don't know what it's going to be, but I have a feeling at some point in the future, there will be a standard and there'll be something which sort of disrupts that industry generally. And just as you can take your driver's license and drive your car in Alaska or Hawaii, you ought to be able to have your information be available regardless of where you are and have it easily accessible. Similarly, from a telemedicine standpoint, right now there's not reciprocity across this country with a physician license, and so we have physicians that are providing telemedicine in surrounding states. They all have to be licensed in the state in which they're providing the care. I think that will change in the future as well.
well, that would be
Just a
something
few
you would.
ideas.
Well, no, that's a great wish list, and I can check all those boxes right alongside you. Hopefully, the incoming administration will address some of these opportunities to really enhance the experience and the outcomes of what we provide on a daily basis in healthcare. Before we let you go, Neil, we'd like to get some insider guidance from our guests. So,
Uh-oh.
the next trip to Baltimore,
Yeah.
what is the go-to spot for the best steamed crab?
Oh my gosh. Oh man, there are so many. Um, I go with Faidley's. I have to go with Faidley's.
Okay. Thank you. We're making notes on all this, and that's kind of a selfish thing to do. But when we hit town, we're going to know where to go. But I'll call you before
You
we
call me if you
arrive.
get down. Absolutely. Absolutely.
Absolutely. Well, Neil, thank you so much. It's been a real privilege. Thank you for joining us. Thank you for enlightening us, and thank you for sharing so much about your thoughts and also the mission of LifeBridge. And again, fascinatingly, care bravely. We
Thank you. It's an
appreciate you.
honor to be asked to join you. I really appreciate the opportunity and wish you all the best in this new year. Thank you.
Thanks so much. That's it for this edition of Megaphone from Medvale Media. I'm Dave Self. Be well.